Welcome. Today we are reviewing the inherited causes of steroid-resistant nephrotic syndrome, focusing on genetics, clinical signs, and treatments according to the comprehensive book Nephrology. It is no doubt that discovery of slit diaphragm genes change everything nowadays. So over 63 monogenic causes are now known. All of them disrupt the podocytes, breaking down the kidney filtration rate. And the steroid-resistant nephrotic syndrome is the second leading cause of chronic kidney disease in children. So nearly 30% of cases have a genetic cause, jumping to almost 70% if symptoms start before 3 months of age. And this is because some mutations that we can see that these mutations damage 5 main areas of the podocyte, as you can see: slit diaphragm, actin cytoscutellin, basement membrane. I think here we have missed the nuclear podocyte. Nucleus also can have some damages that might cause nephrotic syndrome. It must be counted. So recessive forms usually strike in infancy or early childhood, while dominant forms appear later in adolescence and adulthood, and often with incomplete penetrance. We can have some examples. We can see from this table that for older patients, mutations are mostly dominant, and the key genes are the first one, INF2, which is linked to neuropathy, and WT1, which carries a risk of Wilms tumor. And then we can have the mutation in infant and early childhood onset. Mutations are mostly recessive here. NPHS1 causes congenital nephrotic syndrome, and crucially, COQ10 pathway mutations can actually be treated with supplements. And also we have some genes cause severe systemic issues, for example, SCARB2, while Galloway-Mowat syndrome presents with microcephaly and severe brain anomalies. Then we have some critical mutation like WT1, which is Dennis-Drash syndrome, which brings high risk of Wilms tumor requiring early nephrectomy, while Frazier syndrome progresses slower but risk of gonadoplasmatoma. Then we can look for specific physical signs. But for example, INF2 causes peripheral neuropathy, and LMB2 causes small fixed pupils, and LMX1B causes nail dysplasia and missing knee cups. This is some sign that might help us to progress. So pattern recognition is a key. Nephrotic syndrome plus epilepsy means AMRF, and you can see this table, that might help you to find out some associations of patterns. And also, the age of onset predicts the gene. 0 to 3 months points to NPHS1 or LUMP2, and adolescence points to ACTN4, INF2, or TRPC2, and always consider genetics for onset under 25. That's a rule. Because a genetic diagnosis changes everything. Standard steroids will not work. It prevents toxic, useless treatments and opens doors for targeted therapies like COQ10 or vitamin B12. So what is recommended right now is to just test every nephrotic syndrome, which is steroid resistant, started before age 25. Also test adults with a strong family history, and systematically test for APOL1 in patients of African descent. So to summarize, age of onset is your best clue. Look for syndromic features, and remember, finding a genetic cause avoids futile steroid treatments and guides targeted therapy. Thank you.